at the University of Münster, and most of the things that you'll see here today are actually coming from Münster. But I have also talked for companies, and I've received funding from public bodies and companies, and none of this will influence what I'm going to tell you. Always quote your chairman, and luckily I found a paper where both chairmen are co-authors. So what do we know about atrial, or what do we think we know about atrial fibrillation? We know that atrial fibrillation promotes itself by a variety of vicious circuits. The high atrial rate causes a calcium overload in the cardiomyocytes, and that will trigger a death reflex, an apoptotic reflex in the cardiomyocytes, and the cardiomyocytes try to protect themselves against that by shortening the action potential. So they don't die, but that shortens atrial wavelength and then can result in re-entry. And there's a classical gold experimental paper in 1995 that explains it. By the same token, mechanisms that are much less well understood, it's probably the same calcium load that changes the intracellular calcium handling and can lead to triggered activity either through early or through delayed after depolarizations, possibly in the pulmonary veins, and there are a lot of question marks there, but this is one of the other triggers of atrial fibrillation. At the same time, the rapid irregular ventricular contraction leads to a left ventricular dysfunction, to a ventricular filling defect, and to chronic atrial dilation, which by itself, and in the end more emphasized through loss of atrial contraction, will dilate the atria, and that by itself generates obviously a larger area of myocardium where re-entry can occur. Dilation activates several pro-fibrotic signaling pathways, which can lead to fibrosis in the atria, which then will form barriers to re-entry. We know that aging is affecting at least one of those vicious circles, and we think to know that genetic factors, and some of them have popped up before, may affect both the repolarization in the atrium, but also possibly the triggering mechanisms. In several consensus papers, it has already been recognized that especially in young patients, in addition to these mechanisms that promote AF, and in patients where structural heart disease is relatively rare, genetic components are likely to predispose to AF. And we know that the offspring of patients with early onset atrial fibrillation has a higher likelihood of developing atrial fibrillation. There are some monogenic forms, the cardiomyopathies, and we've heard about how prolongation of the QT interval can lead to arrhythmias, and the same can actually happen in the atria. And there are polygenic forms, and to me, these genome-wide association studies that we have just heard in the prior talk about were really an eye-opener upon additional potential mechanisms that can cause atrial fibrillation. Already heard that several genetic variants associated sitting on chromosome 4q25 associate strongest with atrial fibrillation on a population level, stronger than all of the others that you have just heard in the other talk. And interestingly, there has been one, I'd rather say quick and dirty study that suggested that these SNPs also associate with recurrence of atrial fibrillation after catheter ablation. And there has been a larger study in a larger cohort where patients received ion channel blockers to prevent atrial fibrillation, and these SNPs were associated with a higher recurrence rate. So there seems to be some association not only with incident atrial fibrillation, which is what these genome-wide association studies measure, but at least in preliminary data also with recurrence of atrial fibrillation in patients who already have arrhythmia. I think that's an important part to know. It's exciting to see these genome-wide association studies, but the biological readout here is atrial fibrillation diagnosed on a single ECG, so it's more likely to be persistent forms or chronic forms of atrial fibrillation as opposed to paroxysmal forms of atrial fibrillation. Now, PITX2 is a protein that has been studied by developmental biologists for a number of years. Deletion of PITX2 causes what is called Axenfeld-Rieger syndrome, and I had to read that up in 2007. I didn't know about the syndrome, and I don't think many cardiologists will know it. It causes a non-occluding glaucoma. It causes an abundance of umbilical skin, hypodontia, and craniofacial dysmorphism. they have been occasionally associated with extraocular and extrafacial changes, and there are a few case reports, but really very rare case reports that associate them with cardiac abnormalities. I will now try to take you halfway through what I'd like to call a translational research or therapy cycle. It says therapy here, but we are not yet there. So we know about the genetic alteration that associates with the disease phenotype. And if we express that genetic alteration or a similar alteration in a suitable organism, and I'll in the rest of my talk talk about transgenic mice, then we can possibly identify disease mechanisms. And even there, I cannot tell you the full story yet. And then, in an ideal world, we would develop novel therapeutic targets and then propose new therapies which could then be tested in those patients. Mice have been instrumental in identifying a critical role of PITX2 in the embryonal development. If you delete PITX2 completely, you find that the left atrium behaves more like the right atrium, so that you find two sinus nodal horns, as seen here in these embryonal slides, and you also find a altered development of the pulmonary vein myocardium. So if you add these things together and think about catheter ablation, it is a quick jump to say, well, clearly this must be some of the, one of the factors that causes or triggers focal atrial fibrillation. Much less is known about, or has been known so far, and I'll take you through the data that we generated in part, but others helped as well, about the role of PITX2 in the adult heart. The first group who published this, Jim Martin's group, and Dr. Wong was the first author, who studied PITX2 deficient mice with a heterozygous deficiency. Now, before I tell you the story, I have to admit that this is a big leap of faith here. We found a genetic polymorphism, or actually a number of genetic polymorphisms that are close to a gene, and we just assume that these code for variants that cause a reduced function of that gene. And then we just take a mouse model that has 50% of that gene and see whether we find a phenotype in the heart. But follow me on that big leap of faith. They already described that they find PITX2 expressed in the adult heart and almost exclusively in the left atrium. There is one part in that paper that says that it's not expressed in old mice, and we have data that show the opposite. But in general, we are in very much in agreement there. And they also described that when you do a program stimulation in these mice, that they develop atrial fibrillation. We had access to human left and right atrial appendages through our cardiac surgeons in Münster, and could show that PITX2 is expressed to a very high degree in the adult, and then the typical cardiac surgery patient is an old patient, in the adult aging human left atrium. And it is expressed at a logarithmic scale about a factor 100 to 1,000 higher in the left than in the right atrium. And you find the very same in mice, and when you study heterozygous PITX2 deficient mice, you find that they express PITX2 at a level of about 50 to 60% compared to their wild-type mates. So that we really have a model here that expresses the protein of interest, and we have evidence in human and mice that this potential protein of interest is actually expressed in the adult heart. The levels of expression are amongst the highest in the body. It's only skeletal muscle that shows a similar high expression of PITX2. We did then isolated EP studies in the isolated mouse heart, and before that we studied whether the morphology of the heart was changed. So these are murine echocardiography measurements. These are only examples. They show you the transmitral inflow. These show you the flow across the pulmonary valve. And to make a long story short, there is not a single functional or structural alteration. There is no increase in left atrial size. Left ventricular function is completely normal, which you would expect when you know that the expression pattern is confined to the left atrium. Left atrial size is normal. Left atrial function is normal. The only thing we found, but that may be a false positive because we tested over 50 parameters, is that the pulmonary artery velocity, so the estimated pressure in the right ventricle, is higher. And it is worth to note that PITX2 is involved in the development of the right ventricular outflow tract as well. We also tried to identify differences in the pulmonary vein morphology and didn't find any, although it is difficult both histologically and with imaging to really assess that. We also did ultrastructural studies, at least histological studies, and didn't find anything. Cell size seems to be the same. There is no gross fibrosis or changes in extracellular matrix. I have to admit that in some older PITX2 deficient mice, we seem now to find some really funny histological changes, but I will not go into them much further. We then did an electrophysiological study in the isolated beating mouse heart. And we did that using protocols that we had established over the past decade to provoke torsade quant-like focal arrhythmias or early and delayed atrial polarizations. Basically based on the hypothesis that Stefan also explained, that probably PITX2 is somehow related, or PITX2 deficiency is somehow related to focal firing. And we didn't find any ectopy. We also did telemetric monitoring of mice at different ages during stress tests, during provocation of catecholamines with carbachol, during physiological stress tests, during cyclic stress tests. And the number of atrial ectopies is not really different yet. So this was quite a bit of work. It doesn't show up here, and it was a bit disappointing, and it just illustrates how many scientific stories come up with unexpected results. What we find, however, and that was a very consistent finding, is that we could induce atrial fibrillation through programmed atrial stimulation, like the group of Wang and al. Jim Martin could in the in vivo studies. And the only real electrical alteration that we found was a shortening of the left atrial action potential, which, by the way, was only apparent at high physiological pacing rates, because 80 milliseconds is a heart rate of about 750. That is a high physiological heart rate for a mouse, and at low physiological heart rates you wouldn't see any difference. And presumably, although we haven't tested it, if you were to do this in isolated cell preparations where the typical pacing rate is higher than 5 Hertz, lower than 5 Hertz, you would probably not have picked up the That's a difference that we only found in left atrial action potential duration, but it clearly suggests that, at least in this mouse model, reduction of PITX2 changes the repolarization of the atrium and sort of conveys a genetically produced way of electrical remodeling rather than anything else. We also did, together with Uli Schotten in Maastricht, well, actually they were done in Münster but using equipment from Maastricht, conduction velocity measurements, and at least at baseline, at normal pacing rates, we didn't find any changes in atrial conduction.